My name is Tracy Cameron. I work as a ketogenic dietitian in the north of Scotland. Thank you to Nutricia for allowing me to discuss the recent service improvement project that was undertaken in the north of Scotland. This focused on developing an educational pathway using digital technology for ketogenic families. These are my disclosures. The ketogenic diet is an established medical treatment for children with drug-refractory epilepsy, and dietitians are aware that it requires timely, dedicated education for families to manage successfully at home. What I'm going to discuss today is the service improvement carried out in the north of Scotland, providing us with an opportunity to discuss the opportunities available for ketogenic diet education. This will involve talking about digital technology. It will look at a narrative review of the ketogenic diet education and digital resources. Follow on by looking at accounts of families and health professionals in the north of Scotland. And finally, I will touch on the outcomes of the service improvement and how the COVID-19 pandemic has changed our priorities and practice, which I'm sure other centres will be able to relate to. When our dietetic department first discussed introducing digital technology around 2 years ago for the review of patients and to educate families, there was some uncertainty and a lot of thoughts about how we would change the way we worked. The amount of technology available can be overwhelming, and I hope this presentation will make this clearer or at least a little bit more manageable. The North of Scotland Ketogenic Diet Service covers 5 health boards over a large geographical area. This includes NHS Grampian, Tayside, Highland, Shetland and Orkney. We have the capacity to review around 30 children at any one time, and we aim to provide an adequate, timely education to families from the outset. However, evaluation of the service indicated that education provision could be variable depending on a number of factors. These included the age of the child and whether the ketogenic diet was initiated as an inpatient or outpatient. This also included geography, so where the child was referred from. If it was Aberdeen city centre, it was a lot easier for education and dietary initiation. However, if it was one of the islands, such as Shetland, Orkney or Skye, this proved a little bit more problematic. Availability of the dietitian is also another important factor, as none of our dietitians are full-time in the ketogenic diet service and have other clinical commitments. Therefore, we have to manage our service quite well. We knew we needed to become smarter and deliver our service in a more accessible way. I looked at how we could improve our service across the 5 health boards by addressing deficits in practice and hoping to meet the quality standards of effective, patient-centred, timely, efficient and equitable care. Our aim was to work towards providing a more inclusive, effective and efficient service. This would allow adequate time and attention for education. This would mean looking at digital technology to fill the gaps in the service. Our education is defined as delivering a structured programme, so teaching and facilitating activities to empower families in self-management, but also ensuring that colleagues are trained as well, so that we would provide the same service to all. The service improvement was driven by these practice questions. So what would motivate families to learn about the ketogenic diet? What within our education sessions might help to empower ketogenic families? What opportunities did we have available that we could offer families? What were other ketogenic diet teams offering in the way of education and digital technology use? And what would be the best means of sharing practice within the dietetics team? I'll concentrate mainly on what opportunities we had available to offer and what other teams across the UK were offering their families. One of the main drivers to utilise digital technology is that it's thought to be key in transforming healthcare. We aim to allow person-centred care and empower families to manage their own health. In 2019, 95% of the British population were internet users and 80% of the British population were mobile internet users. So a great proportion were using digital technology already. Digital technology has the potential to change the face of our health and social care. Therefore, we wanted to look more into this. But were we welcoming the digital age? It may depend on when we were born. Digital immigrants are born before 1980 and have had to acquire digital skills, compared to digital natives born after 1980, which have grown up with digital technology in the digital age and perhaps find shifting to using technology in healthcare a lot easier than some people would. I completed a narrative review into current ketogenic diet education practices and digital technology. Articles were limited, but the literature available on the use of ketogenic diet as a medical treatment for refractory epilepsy provided the areas of education that should be taught, but there was limited advice on how to best educate families on the ketogenic diet. But I'll highlight some articles of interest. The International Ketogenic Diet Study Group Guidance indicates the vast quantity of education that is required when starting and going through the ketogenic diet journey, but no advice is given on dissemination or which team member is key in providing this information. It was noted, however, that hospital admissions can allow more time for dietary advice and education compared to initiation in an outpatient setting. This article from the Children's Hospital of Philadelphia highlighted the benefits of a ketogenic diet teaching kitchen. All children that were admitted were to participate in 3 group cooking classes supported by a dietitian and a dedicated chef. This is a novel idea, encouraging practical experience and peer support. This hands-on experience is important as 43% of UK adults don't understand health materials containing text, and 61% of UK adults don't understand material containing numbers as well as text. In the UK, the majority of ketogenic diet initiations are in the outpatient setting. Therefore, this model may be seen as resource intensive. However, it may be required for some families that do need more hands-on experience that cannot use text or numbers in literature form. Digital technology available to support health education is vast and includes the following: motivational messaging systems, interactive media, games, web-based education, as well as digital resources such as podcasts, webinars, and social media. Many of these programs can be a great cost to the health board. and would not be cost effective for a small ketogenic diet centre. However, there are free resources that can be utilised, that can be found on the internet. Alternatively, NHS boards may have licence for certain programmes, such as GoToWebinar or GoToMeeting, which are being used a lot more now. Nutrition education programs used in isolation have been shown to be inadequate at changing behaviour. Therefore, when developing a new pathway, it's very important not to solely rely on one educational tool, and we took this into consideration when reviewing our service. This randomised control trial investigated whether an educational video was superior to an interactive web-based module with verbal instructions. This was in children with fractures, and education involved care and therapy of their injuries. The online video showed the greatest increase in knowledge. However, the results were not significant. The authors suggest further investigation into effective educational strategies and environments conducive to knowledge retention. A randomised controlled trial within the ketogenic diet population, looking at variations in education provision, settings, and educational status would be interesting to help us learn more and be able to tailor our educational services. Integrated program technology is another area that would allow rapid access for dietitians to health information of our ketogenic families. Using an app, families can communicate with health professionals through text, video call, or by answering preset questions that may raise red flags. These red flags can be individually determined per centre and could include, for example, hypoglycemia or hyperketosis or any other red flag situation that you may wish to know with regards to your patient. This app can also be used as a medium for education, allowing documents to be transferred at the touch of a button to the families. A one-year pilot within our allergy service in Grampian found that 9 out of 10 parents chose the app for appointments, rating it as an excellent service, and they benefited from remote guidance that was timely, and they were able to receive reassurance. These integrated programs would be a substantial cost to a health board, therefore they may not be for all services. Now more than ever, we are thinking of alternative methods for face-to-face appointments. An alternative mean of ketogenic diet initiation was documented by the Adult Centre at Johns Hopkins. They conducted a prospective cohort study over 3 months to investigate the efficacy of the modified Atkins diet administered via email. The authors demonstrated that digital resources in the form of email could be a useful method of initiating and managing the ketogenic diet in a less resource-intensive way. There was no concern about any of the participants reaching ketosis, and there was a proportion of adults that became seizure-free. In-person interaction, and especially in pediatrics, is important and shouldn't be forgotten, even if it is just through a video call rather than face-to-face. Limitations to using technology such as email or video call include accessibility and inability for people to incorporate this into their lives. Positively, ketogenic dietitians are well versed in using digital technology on a daily basis. They use this to empower families to become self-sufficient with their ketogenic diet and help them calculate recipes. This in turn helps to increase their recipe bank and improve compliance due to dietary variation. These digital applications are welcome aids for dietitians and families, and highlights that families are willing to use technology unfamiliar to them to manage the diet on a daily basis. Heading back now to look at accounts from North of Scotland families that were provided throughout the service evaluation. The families were generally happy with the ketogenic diet service and valued the individual educational approach that was provided. They felt that more practical cooking sessions would be of benefit by the dietitian, and that specific topics of education would be useful. So setting aside time for education on special occasions or a session on sweeteners, something a little bit more specific that they could focus on at one time. The families also mentioned being isolated at times, and they felt that they would benefit from peer support from families in their area. Service evaluation showed that 58% of families benefited from education provided by the wider neurology team, which included dietitians, nurses, pharmacists. 47% advised that social media and charity websites played a big role on their education. This isn't surprising, as Matthew's Friends Cooking channel on YouTube has 8.6 thousand followers at present. A high proportion of our families, 79%, felt that they would benefit from more contact with families through a Facebook group or social media chat group, but mainly if this was related to their area that they lived in, rather than a Facebook group that may be from America or across the UK. On request through Ketopag group, there were 7 replies to a questionnaire from the UK Ketogenic Diet Centres regarding ketogenic diet education and digital use. 40% of centres were already using digital technology in some form, and 60% were looking to develop their service to include more digital technology. 40% reported that they did have dedicated education packages, whereas 60% of centres provided ad hoc education depending on referrals and the needs at that time. 30% would be able to offer cooking education with the dietitian for families that needed this, whilst all the centres were able to organise a cooking education session from a nutrition company chef to come to visit the centre. This is only a small snapshot of the UK centres, but gives an idea into practices pre-COVID. Focus groups were arranged with a small number of patients and neurology staff. Overall, both groups were uncertain about which methods or what technology would encourage learning in families starting the ketogenic diet or throughout their journey. The main outcomes from the focus group were that secure video software should be utilised more, which would enable us to offer a more equitable service across the north of Scotland. This would reduce time wasted travelling or taken out from school or work. It would also reduce the spend for the health board in travel and accommodation. One video-enabled web-based platform that we have been using to educate and review families is NHS Near Me. The usage of this resource has increased from 300 consultations per week in Scotland in February to 15,000 per week in Scotland in June. So there's certainly been a big uptake in this medium due to COVID-19. Near Me and other platforms, dependent on your trust, can be used to allow video calls and education to take place in the comfort of the family's home. There are limitations to this service if families have no access to internet or poor connections. However, there is the option that they can be utilised at the local health centres and using their platforms. Reflecting on current experience, there can be digital reluctance from families, which we need to address and realise that not everyone will feel comfortable on camera. As with all patient contact, practitioners need to ensure that all data is secure and that information governance is followed. For group sessions, at present there is no specific platform to use in Scotland, but this will hopefully be decided later this year. This may be helpful in our patient pathway to use with families to connect with while providing specific education that they have requested. Group sessions would be more beneficial for the dietitians as they would be able to cover all the families at once. This could also be used for group cooking demonstrations requested by families that would like an update or have maybe minimal skills. This is a family experience from one of our ketogenic families on the Near Me platform. Our son had been receiving specialist dietetic support from Dundee and Aberdeen since he commenced a ketogenic diet for management of GLUT1 deficiency syndrome. Previously, this was achieved via email, text message and phone calls with his dietitian. Face-to-face meetings required the dietitian to travel to Orkney to see him or to arrange a video conference using equipment at our local hospital or child health centre. So lots of organisation for us to be able to review this child. We recently had our first video consultation using Attend Anywhere or Near Me application. We accessed this using our laptop at home and agreed to meet in the late afternoon once we'd returned from school. This was much more flexible and convenient than having to attend an appointment elsewhere. Picture and sound quality was very good and better experienced by the NHS VC units. Video streaming enabled us to participate in a discussion which would not have been possible during a telephone call or text conversation. Our initial impressions are that it's accessible, convenient, and easy to use method of meeting with health professionals. No need to travel, access bespoke video conferencing equipment, or to find a room in a healthcare facility. So this approach should prove to be cost-effective and more efficient use of time. We would be happy to make use of the software in future and would recommend this application to other patients and families. So that's a family that is quite far away from our centre, and this was a really useful way that we could see the children and we could see the family interacting. They could bring us products to show on the screen that they were querying whether they could use, or ingredients that was in there, and it was just a more worthwhile consultation than previous ones that we had had. And we now do this on a regular basis up to Orkney. Digital literacy refers to an individual's ability to find, evaluate, and compose clear information through writing and other media on digital platforms. This can vary between families, and there may be a large capability gap. The benefits of digital technology include making connections between healthcare, families, and peers, education provision and real-time updates when face-to-face meetings are limited at the moment, reduction to carbon footprint time and money. However, these benefits are not always obvious to all involved, and some people do resist change and resist the digital way of working. It's important to try and work with these families to find the best solution for them. I completed the service improvement in March 2020, and we had the basis for developing a structured education pathway with face-to-face teaching, education on practical aspects of cooking to be offered to all families, and with a plan to increase our digital usage. Since the COVID-19 pandemic has altered our service, and now we have thought to provide a new digital pathway with flexible working dependent on the family's needs and location. We're willing to embrace learning, working and participating in a digital society and continue to provide a high standard of care to our patients. It's important to be aware of digital reluctance and digital exclusion. In these cases, digital technology shouldn't be forced upon families, but rather working with them to find the best option. Experience pre-COVID showed that only a quarter of patients would choose a digital appointment. Therefore, it's important to find the best way to review our patients. So the way forward for us is to continue to use digital resources that we have available, to be innovative and creative within our team, and always be open to other suggestions. We are looking at small video clips to share with our new referrals to explain the service, and also to show families who is all involved, as if they do come to visit us in the hospital, it's difficult for families to engage and get to know us when we are wearing masks. We also are going to prepare some educational videos, but also utilize ones that are already available, for example, on Matthew's Friends sites or the Nutrition Company's sites. Moving to use digital education still requires techniques to ensure understanding. Using TeachBack, having the parents repeat back in their own words what if they have understood. This is more so over a video link or phone call, as it may not be clear. So always follow up with an email or letter to confirm any changes that you have made. Break down education into small sections and check understanding. Always using simple language and pictures will help immensely. Always encourage questions to help understanding, to offer help, which in turn will empower and enable families to manage their ketogenic diet well. Overall, we want to be innovative and creative and try to enjoy the digital journey that we are on. There are options for using free infographics such as PictoChart, and also using Canva for video education sessions, which may be useful. Also speaking to your communication department within the NHS, and they can help with filming and any other issues that you may want to discuss with them. Thank you so much for listening to our service improvement and digital usage across the north of Scotland, and thank you to Nutricia for hosting this session, and to all the centres that completed the request for data for the service improvement. These are my references.